Welcome everyone. Salam for everyone who speaks Tigrinya. Khamir lahum. Happy Sunday. Thank you for taking the time out of your busy Sunday to be here with us. We appreciate you, and we are going to do our best to make it worthy of your time. Every month, Habesha Health strives to bring professionals and experts in various health topics, and to have a conversation that is useful to our community. So we'd like to know where you are interested in hearing, what topics you want us to address, what health issues impact you and your family and your community, so we can curate those content for you and bring them on a monthly basis. So do send us those questions. After this event, we're going to be sending you an email, and the form is called Community Health Need Assessment. Complete that with topics you're interested in. And I think we're also going to have a link to the chat, to the form in the chat box. So click on that and feel free to send us the feedback. Before we get started, just a few guiding principles / housekeeping rules. If you haven't done that already, please mute yourself so we can have uninterrupted conversation without any background noise. Continue to keep yourself muted until we get to the Q&A session later. And if you have questions, again, send that to us. We have our community team members who are monitoring the chat box. They will be able to fill the questions, and we'll do our very best to address it at the end. And just so everybody's aware, this conversation today will be recorded so we can make it available to our community later. And last but not least, please donate to Habesha Health. The donation that we get allows us to bring amazing events and webinars and other activities like this. So we operate entirely on donations. So it would also allow us future plans that we have to translate the content into Tigrinya, Amharinya, and maybe other languages that are relevant to our community. So your donations are very much appreciated. So we have the housekeeping items out the way. Let me introduce myself, and I'm also going to have our fabulous guest, Dr. Khalil, introduce herself. Many of you may already know who I am. I'm Auguste Waldab, or T, as everybody knows me. I am a marketing and wellness manager in the tech industry here in Silicon Valley. But my first love is wellness, fitness, and all things health and fitness. And for 5 years, I ran a wellness business, doing private coaching as well as corporate wellness programs to corporate clients. So I did that until 2019. And even though now I'm in my corporate roots, I still try to find ways to be involved in wellness, especially now I'm a mom of 2. I have an aging parent. So the topic of health and such as today's is very important, because I want to be around for a long time to see my kids grow. I want to support my mom, who's diabetic and has other health issues. So I'm very happy to be here. And to be quite honest, as much as I love and know so much about wellness, I know very little about the topic of breast cancer. So I'm going to be learning and asking questions right along with every one of you. So that's why I'm very excited to interview Dr. Khalil and learn as we go along. And now let me have the fabulous Tatiana Khalil introduce herself. Dr. Khalil?
Thank you so much, T, and thanks everyone for joining us on a Sunday afternoon today. I'm really excited to be here and share important information about breast cancer. I'm Dr. Tatiana Khalil. I am an assistant professor of radiology at the University of California in San Francisco. I was born and raised in Ethiopia, then moved here to the United States right after high school. And just to tell you a little bit about myself briefly, I did my medical school training at Chicago Medical School. Then I did a 5-year radiology residency. Radiology is a specialty which deals with imaging and diagnosis at Brigham and Women's Hospital at Harvard Medical School. And then I moved to San Francisco and I did a 1-year concentrated specialization in breast imaging and women's imaging. So I'm really excited here to be here today and answer your questions related to breast cancer.
Thank you, Dr. Khalil. Very impressive resume and a Habesha to boot. So we're happy to have you as an expert in our community. Okay, and so the agenda. So I think I said that it's going to be Q&A style where I'm going to be asking a series of questions and get Dr. Khalil to answer them. And if you do have questions, please send them and we will answer them at the very end. And again, please mute yourself if you haven't done already. So let's get started with like the basics because I never want to assume that everybody knows what breast cancer is and what the symptoms are. So let's get started there.
Sure. So, cancer in general is a disease where cells in the body grow out of control and invade adjacent healthy cells. So, in breast cancer, it starts in the cells of the breast as a group of cancer cells, and then it eventually invades adjacent healthy tissue. And if it's not treated at that point, then it spreads to other parts of the body through the lymphatic system and invades other body organs like the liver or lungs and brain or bone. So once it is at that stage where it has spread to other parts of the body, it's usually difficult to treat. And that's why we want to talk about breast cancer, knowing the symptoms early, getting screened early so that it can be treated effectively. And then why should we care about breast cancer? It's actually the most common cancer in women, and it's the second common cause of cancer-related deaths. So it's really important. 1 in 8 women in the United States, for instance, will get diagnosed with breast cancer. So if you have 8 friends or 8 neighbors, one of them will get diagnosed with breast cancer in her lifetime. Or another step that I like is every 2 minutes, women is diagnosed with breast cancer in the United States. So let's say together today, if we spend 60 minutes together, by the end of this session, about 30 women will get diagnosed with breast cancer. So it's a very common disease. It affects women. It also affects men less commonly, but it happens in men and women. So it's really important that we know about breast cancer and what the symptoms are. Before we talk about the symptoms, I want to highlight that just because you have one of these symptoms does not mean you necessarily have breast cancer, but it's important to know what the symptoms are. These symptoms can also happen with conditions that are not cancer. For instance, if you have a breast cyst, it can present with a lump, but just because you have one of these symptoms does not necessarily mean it's breast cancer. But it's important to know these symptoms so that if you notice them, you can go to your doctor and get additional examination and imaging studies. One other point I want to highlight is most women actually don't have symptoms when they get diagnosed with breast cancer, and we catch it on screening mammograms, which we will talk about later. So just because you don't have any of these symptoms today does not mean you don't have cancer. So actually, the majority of women that get diagnosed with breast cancer don't have any of these symptoms. But if you see any of these symptoms, don't delay seeking medical attention. So what should you look for? If you notice any hard or soft lump in the breast or in the armpit or chest that is unusual for you, because you know what your breasts normally feel like. So if you notice a lump that looks different or is growing or is different from the rest of the breast, then you want to see your doctor. If you have sores, for instance, sometimes you get a little pimple or hair follicles that get inflamed, but if the sore doesn't heal and it continues to become larger, that's another sign which is concerning for breast cancer. Or if you have an area that's red or scaly or it's thickened, again, this could be due to breast cancer, but other conditions can cause it too. For instance, an inflammation or infection, especially in women that are breastfeeding, can have some redness. But if that redness doesn't go away after treatment, let's say your doctor prescribes an antibiotic and after treatment there's still redness and thickening of the skin, then you have to be concerned about breast cancer. Or when you look at your nipple, if the nipple is inverted or sunken in, that's another sign for breast cancer. That implies there's a mass inside the breast pulling the nipple. That's why the nipple might be sunken. So that's another sign to be concerned about. Or when you compare your two breasts in front of the mirror, for instance, if one of them looks a little asymmetric, normally the breast might be a little asymmetric, but if there is significant asymmetry out of the normal for your breast, or if there is an area that is bulging or has some dimpling or shrinking, or if the shape looks different from normal, that's another sign to be concerned about. Or if you notice any liquid coming out of the nipple. So especially when it is bloody, meaning it's red in color, or clear like water. When it's milky, we don't worry about it. Even if you're not breastfeeding, milky or green type of discharge is not concerning, but if it contains blood or if it's clear fluid, then that's when we worry about it.
Mm. Wow. Thank you for that visual. That was very helpful. And I just want to emphasize what he said earlier, that men get breast cancer too. And I don't think that this is something that you hear about very often. I, for a long time myself, didn't know this, but and with that, is it also that Black men are more impacted than other races, just as it is with women?
Yeah, that's a great question. Men do get breast cancer. It's less common than in females. Like I mentioned, in females, you get 1 in 8 women will get diagnosed with breast cancer. In men, it's about 1 in 833. So it's less common, but it does happen.
Yes.
And the symptoms are going to be similar as well. So if men feel any lump in the breast, bloody discharge from the nipple, any change in shape or symmetry, same symptoms. If a man notices those symptoms,
Mhm.
they should also get treatment or seek additional diagnosis.
Yeah.
As far as the differences between the different races, you are correct. In women, Black women get a more aggressive type of cancer called triple negative cancer, which is very aggressive.
Mhm.
We don't know why, but the biology of the cancer that they get usually tends to be more aggressive than the ones that white women get.
Hmm.
So Black women usually get diagnosed with breast cancer at an earlier age. So back in the day, people used to assume breast cancer is an old white women's problem, but it's not. Young Black women get diagnosed with breast cancer more often than white women. So that's why it's important for us Black women to get screened at an earlier age. Similarly, in men too, Black men get diagnosed with breast cancer more commonly than white men.
Yes. Okay. And just so we're very clear, when you talk about Black women, we're talking about Habesha women, Caribbean women, all women of a Black race. So that
Yeah,
includes everybody. And the stats that they're not differentiated like for Habesha or Caribbean women or other um, parts of the world outside the U.S. So it's for all that Black race.
yeah, all women. So usually when we do this data collection, we classify it as, white women, African American, Hispanic, or other. So all women of African descent or African heritage are going to be under that
Under
category.
that umbrella. Okay.
Yeah.
Just wanted to get that clarity. So now that we know what the symptoms are and what breast cancer is, what can we do to reduce the risk of breast cancer?
Yeah, that's a great question. So, a risk factor is something that increases the chance of getting the disease. So, women with certain risk factors are more likely to get breast cancer. But that doesn't mean just because you have one of these risk factors that you're necessarily going to get breast cancer. But it means if you have one of these risk factors, you're more likely to get breast cancer than the average women. And there are risk factors that you can avoid or modify, and there are some risk factors that you can do nothing about or you can't control it. The two major risk factors for getting breast cancer are being female and being old. Those you can't control, right?
Mhm.
Uh, but there are some things that you can control. For instance, drinking alcohol has been linked with an increased risk of breast cancer. So if it's possible, not drinking at all is advised. But if you have to, then limiting it to 2 to 3 drinks per week is what's advised. Smoking, again, another predisposing factor for breast cancer. So not just for breast cancer, we know smoking causes lung cancer as well and a number of other cancers. So it's really not recommended that someone should smoke. So and if you're smoking, I highly encourage you to stop smoking, not just for breast cancer, but for a variety of other cancers as well. And being overweight or obese is also associated with increased risk of breast cancer, or not being physically active. So what's recommended to reduce your risk of getting breast cancer is exercising at least 30 minutes a day for 5 days a week. So a total of 150 minutes, moderate amount of exercise. And what does that mean? Like walking for 30 minutes, swimming or dancing, whatever works for you. And what I advise people when it comes to being physically active is choosing something that you're going to be consistent with. So if you choose a type of exercise that you're not interested in, you're not going to be consistent. So for you to be able to reduce your risk of breast cancer, the being physically active has to be consistent. So find something that you like, that you're going to stick with, and do it at least 30 minutes a day for 5 days a week. Another risk factor is not having children. So if you have children, your risk is going to be slightly reduced. And if you do have children, breastfeeding is associated with reducing the risk of breast cancer. So again, we know that breast milk is important for the child too, but this is another reason for breastfeeding, because it reduces your risk of getting breast cancer, slightly reduces it. There are some things that you can't control, like I mentioned. If you're a female at an older age, there's nothing you can do about it. But what you can do is doing your self-breast examinations every month and getting screened regularly so that we can detect cancer early. Other risk factors, if you inherit a certain gene that predisposes you to breast cancer, or if you have a strong family history of breast cancer, that's another risk factor. So that's why it's important to ask your family members, both from your dad's or your mom's side, if there's any family history of breast cancer in your family, so that you can tell your doctor and get additional screening or more frequent screening if you're considered to be at higher risk. So those are some of the risk factors, and some of them you can modify.
Yeah. And with the heredity piece, it's not just like say your mom or your dad, but like does that also like include like extended? So if you have someone who is an extended family member who has it, does that also make you more likely to carry that gene?
That's a very good question. So what makes you higher risk is what we call a first degree relative, meaning one's removed from you. So that would be a mom, a sister, or your dad. Having said that, even though you get your genes from your mom and your dad, if there is significant amount of cancer in your family history, your aunt, your grandmother, it's still important to count how many of those relatives are affected with breast cancer in your family. And there's usually questionnaires that your doctors will fill out to find out how at risk you are by, counting how many members in your family and how by what degree they're removed from you, and they're able to calculate the risk factor. But usually we worry about genetic transmission when it's a first degree relative, like a mom or a sister. If they have breast cancer, then you should definitely get, especially if they were diagnosed at an early age, you want to talk to your doctor about getting genetic counseling and genetic testing. But just in general, it's important to know both from your mom's and dad's side, which family members had breast cancer and how many of them had breast cancer is important.
As much as you can track anyway, because I know that for those of us who grew up back home and who's, a lot of their relatives are back home, that's probably harder to track. But at least we have control of the family members that we do have here. So it's still worth investigating. So now let's talk, if you could just kind of walk us through the process of the exam that you do. So a woman comes and she may suspect there's some kind of lump, or she's feeling something. So what is the process of getting screened for breast cancer? Like maybe on a high level.
Yeah, that's again a great question, and the meat of what we're discussing today. So before even starting to talk about if a patient or if a woman feels symptom, I just want to show how a woman can do a breast self-examination. So we recommend screening mammograms starting at age 40 every year, but you don't want to wait a year to get diagnosed either. So we recommend that everyone performs a breast self-examination every month as well. And the way you do it is usually it's important to choose a specific date so that your breasts might be different at different parts of your menstrual cycle. So just choose a specific date and examine it on the same time every month. So we usually say 2 to 3 days after your period starts if you're still menstruating. If you're not, just choose a date of the month. And then you use the finger pads as shown in the image here, either in the shower or if you want, just use a little massage oil. And there are different ways you can assess the whole breast, either going up and down or in wedges, or starting at the nipple and then going in concentric circles. Regardless of which method you choose, you just make sure that you cover the whole breast and also the armpit. So once you do that, if you notice any of the symptoms that we talked about earlier, like a lump or thickening, then you want to go ahead and see your doctor. And then we talked about one of the symptoms was change in symmetry. So you want to examine your breasts in the mirror, stand in front of the mirror, and then see if there's any change in symmetry between the two breasts, if there's any change in size or skin dimpling, all the symptoms that we talked about earlier, you want to do that. If you don't see anything, that doesn't mean you don't have breast cancer. Like we talked about earlier, even if you don't have symptoms, sometimes you might have breast cancer. That's why it's really important to get annual mammogram for women that are over the age of 40. And for women with high risk, like we talked about, if they have significant family history of breast cancer or some of the genetic mutations that we talked about, screening earlier, starting at 30 years, is actually recommended for women with high risk. And high risk patients are those with significant family history or genetic mutations. If you don't have any of those high risk, everyone should start screening mammogram at 40. So a woman would come once a year to get a mammogram, and this is what the mammogram machine would look like. The breast would be placed between these compression plates, and the technologist is going to get the image. And this is what a mammogram image would look like. Then a radiologist, someone like me, would look at these images. And if there is an abnormality that they see, then the patient will be asked to return for additional imaging. So initially, we just do mammogram. And if we see something that is new from prior or looks a little suspicious, we have the patient come back. Just because you're asked to come back doesn't mean it's cancer. Most of the time, we're able to find out that it's not breast cancer. So the number I use is if we screen 100 patients, 10 of those patients are usually asked to come back for additional imaging. Out of those 10 patients, 6 of them are going to be told, okay, this was nothing. It was just your breast tissue. You can go back to next year's screening. 2 of them will be asked to come back in 6 months for additional imaging, but 2 of them will be suspicious and will be asked to get a biopsy. So after the mammogram, if it's still suspicious, 2 of those 100 patients then will get the ultrasound. Ultrasound is an imaging technique where we use sound waves, and the patient would be laying down. There's no compression or radiation like a mammogram. So we look through the breast, basically take a picture of the inside of the breast. And if we still see a mass that needs a biopsy is where you put a needle into the mass within the breast and take a small amount of sample to identify whether that is breast cancer or not. Just because you see a mass on imaging doesn't mean it's necessarily breast cancer. The only way to find out for sure if it is breast cancer or not is by putting that needle in, taking a small piece of the mass and studying it under the microscope to see if there are cancer cells or not. Then if we prove that that is cancer cells, then the next step would be, to meet with a surgeon and an oncologist and start your treatment. But like I say, the majority of masses are actually not breast cancer. So just because you're called back, don't be concerned that it is breast cancer. And one other important thing is even if you get diagnosed with breast cancer, as long as it's diagnosed early on, the survival rate for breast cancer is really high. About 95 to 99% of people do well. But that is if it's caught at an early stage when it's still tiny and it has not spread to other parts of the body. So that's why it's really important that you get your yearly mammograms done.
Yeah. Wow, this is fascinating. Yeah. So between the time that you take the biopsy and you find out it's cancerous or not, what is that period of time of waiting? Because I imagine it's a very anxious time for women.
Yeah. So usually, at least at my institution, it takes about 4 days. Because the pathologist is a type of doctor that studies cells under the microscope, but they would have to stain it and leave it overnight. So it takes at least 4 days, and we're usually able to let you know in 4 days. Yeah, but like I say, the number is reassuring, right? The majority of these things come back benign or not cancer. But as a radiologist, if we're concerned initially based on imaging, we can tell which ones are going most likely to be cancer. So we kind of give you an idea or a suggestion. This is concerning, or I think this is going to be benign. But usually the wait time is 4 days. I know it's not, it's nerve wracking to wait 4 days to find out. But at least after 4 days.
But yeah, that ultimate peace of
decision.
mind that you get is worth it.
Yeah. And
So,
I forgot to mention, but we use numbing medicine to do the biopsy. So I know some people avoid biopsies because they think it's going to be painful, or even mammograms, they avoid it because they think it's painful, but it is not. And there are things that you can do to minimize the discomfort. So for biopsies, for instance, you get numbing medicine around the mass, so you shouldn't feel any sharp pain at all. So it's kind of like going to the dentist. So
right.
it's not like getting surgery. Some people assume when you say you need a biopsy, they think it's surgery. We put a small needle in after numbing the area and get a small piece of the mass to make a diagnosis. So don't be discouraged from getting a biopsy because of pain.
Yeah, I was just gonna ask that because I have heard where people perceived biopsy with surgery. I just didn't know at all, but that it's painful, and there's also like this perception in our community. If you could address that, um, people have said to avoid getting a biopsy because if you're inserting that needle to get that piece of tissue to test, that I don't know how to say that in English, but in Tigrinya is like, like you're gonna wake up the cancer that is sleeping.
Yeah.
And the minute you insert the needle, that now it's gonna like wake up and spread, and so it's probably some belief that came from I don't know, but I imagine that is not true. But I wanted to hear that from a doctor addressing that head on.
Yeah.
Yeah.
So, like we talked about initially, cancer is a disease where cells grow out of control, right? So, whether you put a needle in it or not, it's going to continue to divide and invade. So, the needle is not going to change the mechanism by which cancer gets bigger. So, putting a needle in it does not make the cancer more aggressive or invade adjacent tissue. Regardless of what you do, if you're not treating the cancer, it's eventually going to divide and take over the neighborhood. So it's really important. Biopsy is the only way to 100% assure whether that's breast cancer or not. Imaging by itself tells us it's more likely to be cancer or less likely to be cancer, but the gold standard or the way to find out whether it's cancer or not is through a biopsy. There's no other way. So it has to be done. And there's no evidence that putting a needle is going to spread the cancer or it's going to wake it up and make it more aggressive.
Yeah. Well, you heard it, guys. So you heard it directly from the doctor. Now we know that. And to your point earlier, like, so you do a numbing agent thing. So when you do the biopsy, that it's not painful. But even if there is a slight discomfort or a little bit of pain, and especially if you are a woman over the age of 40 with high risk, um, if you're not taking that initial discomfort, I imagine the pain that would come later would be significantly worse, and especially if it's not caught on time. So it just kind of like weighing the risk and which pain, and that pain analysis caught early and addressed early with the biopsy is a better way to go.
Definitely. Yeah.
Yeah. So okay.
That's
So those I don't know if you have anything else you want to add. Those were like the basic baseline questions that I have. I do have 4 or 5 questions that came from a survey that I did to our community prior to coming to this. And we may also have questions from our audience. But before I ask those questions, I don't know if I've left out anything as it relates to not just breast cancer, but breast cancer and the Habesha community that is maybe relevant to our community, that maybe any myth that you would like to dispel, or anything that is relevant to us that you wanted to impart to our audience.
Yeah, so one of the things that I want to address is at least what I gather from talking to my Havershaw family members is there's this stigma against being diagnosed with breast cancer. But breast cancer is a disease just like any other disease, like diabetes or asthma. So there shouldn't be a stigma against being diagnosed with breast cancer. And when someone in the Havershaw community is diagnosed with breast cancer, no one talks about it, or we don't want to tell our family members or friends or our neighbors, and it's kind of kept hush hush. But
Yes.
it's really important to share that information with others, one, so that others are aware and can get screening and the self-breast exam and regular screening to minimize the chances of, advanced disease. But more importantly, so that those patients get support from the community as well. If you're hiding it and not talking about it, you're not going to get support from the community. So I just want to, speak against that stigma. Cancer is not a special type of disease. It's just like biology, any other disease, asthma or diabetes, like I said. So just because you're diagnosed with breast cancer or any other type of cancer, it shouldn't be taken negatively. And it's really important to seek care as early as possible, because that's when treatment is most successful.
I agree. I just think that it's so important in our community to talk about these things, which is why I'm so grateful that after our discussion, we do have a video of women who are breast cancer survivors that are going to be sharing that. And again, I think I said it was created in collaboration with Habesha Moms, also known as Almaz & Co., and Habesha Health. So we have put that so other Habesha women can see themselves that yes, it does happen to us. We're just like any other people, and just because people don't talk about it, it doesn't mean that it's happening. That it's not happening. So I couldn't agree that what you don't talk about, what you don't air, you can't heal. So I absolutely love that, and thank you for emphasizing that, because we don't do enough talking
Yeah.
and the same with COVID. That's also like, no. So breast cancer, COVID, any of these things, it's not a punishment. It's not shameful. It's not something that happened to you because whatever. It just is. There are, like Dr. Khalil said, there are so many factors, so many reasons: environmental, genetical, economic, socioeconomic circumstances. There are just so many factors that affect why somebody gets breast cancer. So it's not your fault and it's not a punishment. And I hear that a lot in the Habesha community. Like, why is Amlakhantai Gerayo? Like, what did I do? Not it. That's not it. But I'm gonna stop lecturing now. So I'm gonna bring some of the questions. So if I'm looking down, you guys, I am also getting questions on my cell phone to read. So that's what I'm doing, just so you're aware. So one of the questions that came in was, why are Black women at higher risk than Caucasian women and other races of getting, especially the aggressive type of breast cancer?
Yeah, so the mortality or death rates among Black women is about 40% higher when compared to white women. So the incidence of breast cancer is similar in both, but like I said earlier, Black women get a more aggressive type just by genetics. We don't know why they get the triple negative or the more aggressive type of cancer. They also get diagnosed earlier. So the peak age for white women is between 50s and 60s, but for Black women, they actually get it earlier than 50 years. In their 40s is when it peaks. And sometimes we see it early and then 40s as well. So that's another difference. They get diagnosed early at an earlier age with a more aggressive type of breast cancer and at an advanced stage, meaning There are different stages of breast cancer. When you catch it early, it's stage 1, but if it has invaded other parts of the body and distant parts of the body, then it's stage 4. And Black women get diagnosed with later stages of cancer, stage 3 or 4.
Yeah.
The reason for that is multifactorial. One is socioeconomic status, not having an insurance, not having access to screening, or living in a rural area where they don't have access to imaging. The other is the stigma that we talked about, that people might not be inclined to get screening or go seek help until it's too late, until they feel something, which is already too late. And part of it is just biology. It's just more common. A more aggressive type of cancer is more common in Black women.
Okay. Thank you for that answering. So I'm going to read a question that just came in. For those of us who don't have valid family history of medical disease, would you advise getting tested or evaluated for the gene that causes breast cancer? If so, do you know if this type of testing is covered by insurance or offered at any age with no knowledge of a family history of breast cancer? Thank you.
That's a great question. So the American College of Radiology actually recommends for Black women to get high-risk screening at no later than age 30, meaning by the time you're 30, you should talk to your doctor about what is my risk. So the next time you see your PCP or OBGYN doctor, ask them, what is my risk factor? What's the level of my risk for breast cancer? Because like we talked about, it's noticed earlier in Black women. So just don't wait until screening age of 40 to find out if you're at high risk or not. So to assess whether you're high risk or not, there are a number of questionnaires that your doctor is going to fill out and calculate whether you're at high risk or not. So family history is one portion of it, but it's not everything. They will ask you about what age you had your menstruation, whether you take birth control or not, whether you were pregnant, what age, if you were breastfeeding. So they calculate your risk by compiling all of that information. Family history is part of it. They also look at what's called breast density, but there's a number of questions that they look at, and then they calculate your risk. If you're over 20% risk factor, or if you have a significant family history, they'll recommend that you get screened at an earlier age, starting at 30. Okay. For the genetic test for the breast cancer genes, there's one called BRCA1 and 2. Those are the most common breast cancer related genes. Usually they would require a first degree family member that is known to have breast cancer, a mom or a sister. And they would either test those people in your family that have positive breast cancer or yourself. And usually if you have family history, it is covered by insurance. But this is something that you should bring up with your doctor, and usually they will send you for genetic counseling and they'll tell you whether you should get breast cancer gene testing or not. It's not advised that everyone gets tested for it because not a lot of people have it. And actually the majority of breast cancer is not related to genetic history. It's just part of the risk factors, but about 80 to 85% of breast cancer is sporadic, meaning it's not related to family history. It's not related to gene mutations. So actually the majority of them happen and we don't know why they happen. So I don't want you to get bogged down with, I have to know whether I have the gene mutation or not. If you have significant family history, you should definitely get tested for the genes. But if not, just do the common precautions of exercising, avoiding alcohol, and maintaining a healthy weight, and doing your self-exam every month and getting screened at age 40. And if you're younger than 40, asking your doctor what your risk level is starting at age 30.
Okay, that's great. Hopefully that answered the question. And if you do have a follow-up question, again, just go to habeshahealth.org and we have our email there. So we will be we can send Dr. Khalil the follow-up question to that. Okay, I'm gonna read another one. There, excuse me. There is a taboo in our community against mammograms due to the belief that mammograms itself will cause cancer. Can you speak to that, and what studies are there as far as the risk versus benefit of mammogram? Thank you.
That is a very good question, and I'm glad you brought it up. So yeah, there's a lot of confusion about mammograms that deters people from getting it. So I'm glad you brought that question up. So the dose that we use for mammograms is very, very low. So just living in the United States or anywhere in the world, there's background radiation just from existing in the world. So the dose of radiation that you get from a mammogram is the same as flying from, let's say, Boston to San Francisco. A 6-hour flight is the same amount of background radiation that you get as one mammogram. Or if you were to live in Santa Fe for 1 week, it's the same amount of radiation as getting a mammogram. So that tells you just existing in the world, there's some sort of background radiation that exists, and the dose of mammogram is very, very low. So cancers related to a mammogram are very, very rare. I think it's 1 in 10,000 or so. But the risk versus benefit analysis, there are multiple studies that have shown getting regular screening mammogram reduces mortality or cancer-related deaths by 40%. That's close to a half, right? So people, if you compare a cohort of people that get screened versus those that don't get screened with mammograms, the ones that get screened have 40% less deaths. But the cancer-related, radiation-related cancer is very, very rare. And there are multiple studies that have shown the benefit far outweighs the risk. And just existing, like I said, in the world, you're going to get the same amount of radiation from flying or from being out in the world. So it's a very low dose. And so I don't want you to worry about the harmful effects of radiation. That shouldn't be a reason not to get a mammogram.
Yeah. So the gist of it is that
It's very low dose.
very low dose, not any more than just existing in the world, and the benefit far outweighs the whatever perceived harm that there is.
Yes.
Excellent. So I will say that we are getting lots of questions, which is great. And we may, just giving a heads up, we may not get to all the questions today. And Tatiana, do keep me on track. So because I want to respect everybody's time, we still have a video. We still want to be able to send you guys off to enjoy your day. But I'm going to read a couple more here and a couple from there. Hopefully, Dr. Khalil, you're not, you're still with us. Said, I understand that cancer in general is triggered about 85% of the time spontaneously. Why do we focus so much on looking for genetic link family history?
That's another great question.
I think a follow-up question with that is biopsy the most accurate way of detecting breast cancer, or can a CT scan also help? So first, why do we focus 85% on the genes? And is biopsy the most accurate?
Those are, again, great questions. And that is correct. I just mentioned that a few minutes ago, that the majority of cancer is actually not related to family history. 80 to 85% is sporadic or spontaneous. The reason we ask for genetic link or family history is those with family history are more likely to get breast cancer, even though the number is less, like only 15% of breast cancer is associated with family history or genetics. Those with genetics have a really high chance of getting breast cancer. To give you an example, an average woman has 12% chance of getting breast cancer in her lifetime. Someone with a genetic mutation like the BRCA gene, they have up to 80% chance of getting breast cancer. So even though the majority of breast cancer is not related to genetics or family history, ones that have genetic history are most likely going to get breast cancer. That's why we want to identify those patients that have family history and screen them more closely and screen them with additional studies. So for all of us, we recommend mammogram, but for those who have genetic history, we also recommend, in addition to mammograms, getting an MRI. So an MRI is another type of exam, which is more sensitive than a mammogram, but we don't want to recommend it to everyone because, one, it's expensive and it uses an IV contrast. So that's reserved for people that are at a higher risk, like those with genetic mutations or family history. So that's why we want to identify it, not because we want to ignore the 85% that don't have genetic or family risk factors, but those that do have genetic mutations or family history are more likely to get breast cancer than others.
That makes sense. Okay, that is 80%, huh? That is
if they have the breast gene mutation, the one BRCA1, BRCA1, 70 to 80% chance of getting breast cancer. And that's why some of those women choose to have their breasts removed even before they get breast cancer as a prophylaxis, because the chances of them getting breast cancer is really high. And the other question I didn't answer, biopsy is, yes, the most accurate way of detecting breast cancer. CT scans are done to assess if the disease has spread to somewhere else. So CT scan is ordered to see, is the disease confined to the breast or has it spread to other parts of the body like the lungs or brain or bones? So CT scans are not used to diagnose breast cancer, but they're used to see if it has spread to other parts of the body. So the most useful exam is mammogram, meaning because that's the one that has been demonstrated to reduce mortality. Then once we see an abnormality, that most accurate way of proving that it's breast cancer is doing a biopsy.
Okay, great. Okay, I think I'm going to shift to some of these questions here too, because I think they're pretty important. So somebody did wanted to know, and you may not have the data for this, but how common is breast cancer in the Havershaw community? How often do you see it in your practice?
Yeah, so we don't have data that is just for the Hobasha community, like I mentioned earlier. The incidence is the same. It's similar in white and African American women, but again, African American women, which would also include Habesha community, are usually diagnosed with a later stage aggressive disease and at a younger age. But I do see Habesha people in my practice.
And you said the ones that you have seen, by the time they come to you, it's usually has progressed.
Yeah, unfortunately, yeah, most of the Habesha people I see in my practice, they come at a later stage that has already spread either to their lymph nodes in their armpit or to other parts of the body. And they usually don't come in until they feel a large mass. You know, by the time you feel it, it's already big enough, right? We want to catch it when it's less than 1 centimeter. And that's why screening mammograms are really important.
Yeah, very important. I mean, it's a matter of, if you get to stage 3, 4, and, I imagine your risk of death then significantly goes up at that time.
Significantly higher, yeah.
Okay. So let's say that a woman over 40 is doing her annual mammogram, but she doesn't have or wants to begin, a woman who just turned 40 and she doesn't have insurance. And I imagine there are a lot in our community who don't. What are resources that are available so that doesn't deter people from going and doing this life-saving examination?
Yeah, so Medicare and Medicaid usually cover screening mammograms. But if you don't have that, I'll just share my screen very quickly. But there are websites and phone numbers that you can use to call and to find out in your area which practices provide free screening mammogram. There usually is a center in your city that provides free cancer screening. For instance, where I am in San Francisco, the county hospital, the San Francisco General Hospital, provides free cancer screening for women without health insurance. So you can call these numbers, the National Cancer Institute or American Cancer Society. You can, snap a picture of that if you would, and call them to find out, I don't have insurance. Is there any center in my city that provides free screening mammograms? Or sometimes if there's no free screening mammogram, they usually do it at a lower cost for people with no insurance.
And the video is being recorded, so this information will be sent out to all our attendees. So if you haven't had a chance to write it down, don't worry about it. So I think what we're going to do right now is we're going to play the video of our wonderful survivors have shared. And then if we do have time, we may take 1 or 2 questions after, but we've essentially already done the Q&A. Again, the video, it was made in collaboration with Havershaw Health and Almaz & Co. Yeah, so let's roll it and all of us watch it.
Hi, I'm Mahalit Karma. I have two questions to answer. The first question says, what word describes your experience surviving breast cancer? For me, it's staying positive, and not letting cancer get to you, and faith, and also having humor. And then the second question is, what is one advice you can give to others regarding screening? And I can say early detection saves lives, so you have to do it. No matter what, you have to make that appointment. You have to follow up. And screening sometimes, you do it mammogram and they tell you to come back for a follow up. You don't need to be scared. It is to clarify the mammogram result, and it's good. The more you push on, the earlier it's found, your higher chance of not having breast cancer, or actually treating it is better. So you gotta do it yourself, so advocate for yourself and get your screening. That's it. Thank you.
Hi, I'm Eden. I'm a 4-year breast cancer survivor. I got diagnosed in 2016 with invasive ductal carcinoma and estrogen hormone induced cancer. You have cancer. Those are the three most terrifying words anyone can hear. I was in my late 30s, breastfeeding my 18-month-old daughter, and I had a 3-year-old son at the time. It was the hardest thing for me to hear. If breast cancer found early, there are more treatment options and a better survival rate in the first 5 years. So please do your self-exam, your mammogram, MRI, breast ultrasound, ductogram, which help us to find the cause of the nipple discharge, and the nipple discharge exam. A cancer diagnosis does not have to be a death sentence. Early detection saves life.
Thank you. Thank you to Mahlet and I forgot the other name, who were courageous enough to share their stories and journeys. I think that's something that we should do more, not only to dispel a lot of this myth, but to give hope to other women that may be suffering in isolation and thinking, or even just having the perception that this is not something that happens in our community, because it does all the time. We just don't hear about it as much. So thank you so much for that. um, I think, let's see what time it is. I think we may have a couple more questions, and then are there a particular type of breast cancer that is more likely to be genetically linked?
Yeah, so women with genetic mutations usually get what's called a triple negative breast cancer. So there are, I don't want to get too technical, but there are cancers that have estrogen receptors and progesterone receptors, and one that's called HER2 receptor. And the triple negative type of cancer doesn't have any of those receptors. So the importance of that is, if the cancer has that estrogen or progesterone receptors, you can treat it with hormonal medications or hormonal treatment. The triple negative cancer does not have any of those targets for hormonal therapy, so it's usually harder to treat. So that's why genetic mutations are associated with that, what's called a triple negative cancer, and it's usually more aggressive and harder to treat because it doesn't have that hormonal target.
So that becomes especially more important to catch early.
Yes. Yeah, that's why we aggressively screen those people with mammograms and also add MRI and start screening at age 30, because once they get cancer, they usually get the more aggressive type of cancer.
So, and just out of curiosity, for the triple negative, if you're just doing your monthly test or try to check yourself at home, how is it easier or harder to detect? Just curious, because if you have a risk of that, you probably will be doing that more often before you even get to the annual mammogram piece of it. So I don't know if it presents differently or it's just like any other breast cancer that shows up on your tests.
It grows more faster. That's the thing. So women, the ones that are diagnosed with triple negative usually tell us, oh, I just noticed this 2 weeks ago and it's already a big mass. Usually breast cancer doesn't, advance that fast, but those with triple negative cancer, the size grows very fast. So they usually come in with a rapidly growing mass.
Wow. Okay. Well, there you have it. And I'm gonna take one more question, and then I think we're gonna wrap up. I know you guys are still sending the questions, and please continue. Even if we don't address them here, we want to be able to hear what we may even consider doing a follow up or just respond to you via email. We'll find a way to respond. It said, I think people have the wrong perception that if cancer is not in their family history, they don't have to worry. Can you speak to the prevalence of reoccurrence and developing secondary cancer?
Yeah, that's a very important point to mention, because like we said, 85% of breast cancer is actually not associated with family history. So don't be fooled just because there's no one in your family with history of breast cancer. That does not mean you're not going to get breast cancer. The majority are not associated with family history. So it's important to know if you have family history so that you can get screened earlier and more frequently. But just because you don't have family history does not mean you're safe. So it's important that everyone gets a yearly screening mammogram. For recurrence of breast cancer, yes, it does recur sometimes. And that's why we closely monitor patients that have had breast cancer followed by breast cancer surgery. If it recurs, it usually happens in the first 5 years or so. So at my institutions at UCSF, for instance, we image those patients every 6 months instead of every year, because we want to keep a close eye on them to make sure there's no recurrence. If they were diagnosed before age 50, we also recommend adding MRI in addition to a mammogram so that we don't miss recurrence. So we watch patients that have had history of breast cancer more closely, and we image them with mammogram and MRI, especially if they were diagnosed before age 50.
Very, very informative. Yeah, and again, this video is being recorded, so I know there are a lot of statistics and numbers that we threw out. Please go back and listen to it, especially with your loved ones who may be at risk or who do need the translation into Tigrinya or Amharinya. You want to be able to watch it with them and educate them. Unfortunately, we are going to stop not here. Just email us some of the questions that are coming in. I just want to go back to the video we were watching earlier, and I wanted to acknowledge Eden Berhane. She was the other survivor who shared her breast cancer survivor experience. So Eden Berhane and Mahlet, thank you so much. We appreciate you. Thank you for being vulnerable and sharing who you are. So that's it for now. I know we could probably do this for 3 hours, but it's Sunday and we'll let you guys go. Dr. Khalil, thank you so much for your insightful conversations. I personally learned a lot that I did not know about myself. So it's been excellent to hear and to have an expert here in our community. Thank you for making yourself available.
Thank you.
And thank you. And we're going to continue this conversation on the various social channels for Habesha Health. So if you go to habeshahealth.org, we have a link to Instagram, Facebook, and the various channels. So continue to bring those questions there, and and just let's have a conversation. And then next month we're gonna have an expert on dementia and Alzheimer's. So it's gonna be another very important topic for our community. So please sign up when the sign up becomes available. Dementia, as you know, and Alzheimer's is also very common in our community. So it's going to be another very engaging conversation. And then one last thing, vote, 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 vote. So November 3rd is vote, but if you can, send your ballots before that. In terms of healthcare and all the things that affect our community, this election could not be more detrimental. It is very important that you vote, that you take people and drive them to the voting station, and our voice and our vote matters, so please vote. Vote for our kids, vote for future generations. I know Barack Obama's election was big, but this will have a huge impact on our lives. So don't forget to vote. With that's it for this topic. Thank you all, and we will be sending the recording shortly. Thank you, Dr. Khalil, again.
Thanks, everyone. Thanks for joining.
Bye.
Bye.